This is a machine under constant, violent mechanical stress. When medical professionals first study cardiac valves, the focus usually snaps straight to the audio, memorizing the exact acoustic pitch and timing of a stenosis or regurgitation murmur. A murmur describes the sound of pressurized fluid crashing into a broken mechanical component. To deeply comprehend valvular pathology, we have to mute the audio and analyze the heart exactly for what it is, a high-pressure biomechanical engine. We will map specific structural tissue failures to identify the mechanical reality behind those turbulent sounds. To pinpoint where these failures happen, we first need the correct vantage point. The most optimal way to view the mechanical layout is from the superior transverse plane, looking straight down into the chest. This diagram shows all 4 cardiac valves operating simultaneously. From top to bottom, you can see the pulmonic, aortic, mitral, and tricuspid valves. If we isolate the left side, we are left with 2 active structures, the aortic and mitral valves. These 2 specific left-sided valves will serve as our primary focus because they are where the vast majority of clinical valvular pathologies occur. Establishing this spatial map is the foundational step required to predict exactly where and why mechanical breakdowns will inevitably take place. Clinical data shows that valvular pathology is disproportionately concentrated on the left side of the heart. This split cross-section visualizes the physiological reason behind that concentration: pressure asymmetry. The particle flow on the left reveals a high-velocity, high-pressure environment, contrasting sharply with the slower flow on the right. The left ventricle is the cardiovascular system's workhorse. It must generate enough force to overcome systemic resistance and pump blood to the entire body. The right side of the heart carries a much lighter physiological burden, requiring only enough pressure to move blood through the adjacent, low-resistant pulmonary circuit. That intense systemic pressure on the left equates directly to extreme, repetitive mechanical wear and tear on the valve tissues over a human lifetime. Think of the physics involved. With every systolic ejection, blood exerts severe concussive force against the left-sided valves. In contrast, right-sided valves experience lower pressure splashing. Anatomical location dictates the mechanical load, and that load determines the probability of structural failure. When these valves do break down, the failure generally falls into one of 2 categories. The first is intrinsic tissue degradation, where the actual physical material of the valve breaks down. This microscopic cross-section shows a healthy left-sided valve leaflet pivoting cleanly on its hinge. The most frequent intrinsic pathology disrupting this movement is calcification. Over time, calcium ions, fat, and cholesterol physically accumulate, stiffening the valve and restricting its motion. Pathophysiologically, the mechanics of this valvular calcification are identical to the buildup of atherosclerotic plaque in the arteries. The second intrinsic pathology is connective tissue degeneration. If we strip away the surface, we see the structural wireframe. When the foundational proteins making up this lattice fail, the valve begins fraying and breaking apart. Connective tissue disorders, such as Marfan syndrome, compromise these structural proteins, leaving the valve dysfunctional. The third intrinsic pathology is driven by biological invasion, infective endocarditis. Pathogens circulating in the blood physically adhere to the surface of the valve, triggering a localized destructive inflammatory response that rapidly degrades the tissue. Whether caused by rigid calcification, genetic protein breakdown, or invasive infection, intrinsic pathologies destroy the physical capability of the valve from the inside out. The second major failure pathway is extrinsic support failure. A perfectly healthy valve can still fail if its surrounding moorings give way. This coronal cross-section allows us to examine the vertical support structures. Notice the bright white area glowing at the base of the valve. This is the annulus. The annulus is the fibrous anchoring ring that holds the valve cusps in tight, proper alignment. In conditions like an aortic aneurysm, the ballooning outward of the arterial wall forcefully stretches this foundational ring wider than its normal shape. As the surrounding muscular and vascular structures dilate, they mechanically pull the annulus outward in all directions. This geometric distortion drags the healthy valve cusps laterally. They are physically prevented from touching, leaving a clear gap in the center. This gap is a regurgitant orifice. Severe retrograde blood flow occurs because the structural canvas supporting the valve has been stretched too far. Moving deeper into the left ventricle, we encounter an active, tension-bearing anchoring system. Panning down into the chamber, we can identify the papillary muscles on the ventricular wall, connected to the mitral valve by string-like cords known as the chordae tendineae. These muscles and tendinous cords provide active downward tension to prevent the valve from blowing out backwards under immense systolic pressure. But under enough mechanical load, these physical anchors can fail. A ruptured papillary muscle or snapped chordae tendineae is a catastrophic mechanical failure. The moment a cord snaps, the tether is gone. The upward pressure instantly forces the mitral valve leaflet to flail backward into the left atrium. Completely untethering a valve instantly destroys its ability to maintain unidirectional flow, turning a highly pressurized engine into an inefficient pump. Valvular heart disease follows a predictable pattern of mechanical failure. This matrix unifies the structural breakdown. Every failure stems either from intrinsic degradation of the tissue itself or extrinsic support failure of the anchors. Because extreme systemic pressure forces higher mechanical wear, both types of failure are concentrated on the left side of the heart. By utilizing this framework, clinicians can listen to a murmur and logically reverse engineer the specific structural reality causing that turbulent flow. Understanding these conditions begins by analyzing the heart through the principles of pressure, tissue, and tension.